Stroke and TIAs are, very common, particularly as we age in our elderly patient population. Can certainly happen at times in younger populations as well. But I'm going to talk about acute management here. Also going to cover, some of the agents that are used longer term, and then differentiate, a little bit between the different types of stroke. So types of stroke, so we've got hemorrhagic, and with that, that's basically bleeding out, bleeding in the brain, and that causing inadequate perfusion to the brain and causing some damage, some issues there. A TIA is basically a trans-ischemic attack, so it's this kind of intermittent stoppage of blood flow, but not a true blockage typically. And symptoms of TIA generally resolve on their own, but you may get patients reporting an episode, of maybe slight visual changes for a short period of time, and then it resolved. And so it's really important to encourage patients to report symptoms like that, just to make sure that a bigger event isn't brewing, and we can manage with anticoagulation if appropriate, or antiplatelet agents if appropriate there. Ischemic stroke, so this is the most common type of stroke, and we've got two common types of stroke to differentiate the ischemic portion. So localized ischemia, so this is due to kind of those plaque, fatty atherosclerotic buildups in the brain that essentially block off that blood flow. Okay, so that's atherosclerotic origin type of stroke. Now the other type of stroke is kind of classic in atrial fibrillation, where we've got a clot forming in the heart region, and that clot basically gets sent through the arteries and up into the brain and causes a blockage in the smaller vessels of the brain. So there is differences between those two types of stroke. Symptomatically, you might not see too much of a difference. You might get kind of the classic stroke symptoms. But as far as management, drug treatment, after we identify which type it is, there is definitely a difference. So signs of stroke, we've got facial drooping, one-sided arm weakness. So if you kind of ask patients to, push down on your hands or push against something, you can feel if they can't push as strongly with one hand versus the other. You may see leaning to one side, or maybe an arm is hanging there. They're not able to move it quite as easily. Slurred speech can happen, confusion, vision changes are often reported. Again, this really depends upon where that stroke takes place and where at in the brain that's affected. May often see it cause a fall, where we've maybe got weakness to a whole one side of the body that, as a patient was walking, moving, that causes them to have a fall. So maybe they're found by EMS on the floor, for example. So those are just kind of a few classic signs and symptoms of stroke. Acute ischemic stroke management. So we're going to try to do reperfusion and TPA. And with use of TPA, the quicker the better for administration. Obviously, we don't want to use TPA in a hemorrhagic stroke, but if we've identified that it's due to blood clot, vessels clogged up, TPA is the drug of choice here. 90 minutes or less is typically what we want to target for sure. There definitely is evidence, a little bit further out, and will likely still give that TPA within, a 6-hour range, for sure. But like I said, as we get further out, the evidence, the benefit is less and less. And if you think about that from a common sense perspective, that makes sense, where that blockage is going on for a longer and longer and longer period of time. Ultimately, that tissue, that perfusion, that blood flow is being blocked from, can ultimately die and be permanently damaged. Exclusion criteria, so I think this is really important to remember. So if patients have had a history of intracranial bleeding, if we give an agent that's going to increase the risk of bleeding, that's a potential reason why we wouldn't give it. If they've got an active bleed, active hemorrhage, that's kind of happened in the last 21 days. Let's say they've had a recent traumatic event, a substantial bleed, internal bleed, anything like that in the last 3 weeks, that would exclude them from us wanting to use TPA. If blood pressure can't get under control, BP greater than 185 over 110, obviously we've got some risks in giving a medication that's going to increase bleed risk there. A recent head trauma surgery, again, probably increasing that risk of any sort of intracranial bleed. INR greater than 1.7. So we'll want to do that assessment, check some labs upon initial assessment, try to get those back as quick as we can. Heparin, use of other anticoagulants, including some of the newer agents now. Definitely important to keep that in mind. Platelets, I think that's kind of common sense to take a peek at that. Glucose, we want to make sure that they're not having a hypoglycemic episode, and that's contributing. So we'll want to make sure that they're not hypoglycemic as well, which can be kind of a differential part of the diagnosis. And endocarditis is also an exclusion criteria. Classic risk factors for stroke: hypertension, smoking, atrial fibrillation, diabetes, hyperlipidemia, age, genetics. So a lot of these factor in with our atherosclerotic risk factors for heart attack as well. Probably the bigger exception there being the atrial fibrillation, where that's kind of a specific risk factor. And I definitely did talk, more about that atrial fibrillation in kind of its own separate section, and the risk of clot formation and Chad's 2 Vasc and things of that nature. So check out the atrial fibrillation if you want to learn a little bit more about anticoagulation and those medications there. As far as prevention of stroke, it's important to manage those modifiable risk factors. Blood pressure, smoking, weight loss, diabetes, statin use, all important things to do there, and can help reduce the risk of stroke. So options for long-term management of stroke. So here we're focusing on those medications that kind of thin the blood. For atherosclerotic stroke, we need to use Agrinox or clopidogrel. They're usually the first line agents. Ticlopidine is indicated, but generally avoided due to the substantial risk of neutropenia. In the event a patient doesn't tolerate, won't take Agrinox or clopidogrel, you definitely may see aspirin utilized. Cardioembolic stroke, so atrial fibrillation, which again I'll talk a little bit more in kind of separate sections. I've got separate section on warfarin and the DOACs or the NOACs, the novel oral anticoagulants. I'll talk a little bit further about those. In patients that don't want warfarin, they don't want any blood thinners, oftentimes patients are receptive to baby aspirin and or the 325 milligram dose of aspirin. So again, looking at the risk-benefit strategies there in that cardioembolic stroke, atrial fibrillation. Age is something to think about, quality of life, life expectancy, all those things are good factors to think about in using warfarin versus aspirin, or NOACs versus aspirin.